Hello and welcome to the How I Practice series for WPSI's recommendations on screening for breast cancer for women of average risk. My name is Dr. Amy Farkas, and I am a member of the Dissemination and Implementation Steering Committee. First, I'd like to note that this project is supported by the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services, under a grant for Bright Futures for Women's Health Standard Practice Guidelines for Well Woman Care. This information or content and any conclusions are those of the author and should not be construed as an official position nor policy of, nor should any endorsement be inferred by HRSA, HHS, or the U.S. government. My name is Dr. Amy Farkas, and I am a member of the Dissemination and Implementation Steering Committee, representing the Society of General Internal Medicine. I am an associate professor at the Medical College of Wisconsin. My research interest includes clinical women's health, medical education, and women's leadership. I have no conflicts of interest. First, some background information. Breast cancer is the most frequently diagnosed cancer among women in the United States after skin cancer and is the second leading cause of cancer deaths after lung cancer. According to SEER data, approximately 297,000 new cases of breast cancer were diagnosed in 2023, comprising 15.2% of all cancers. And 43,000 deaths occurred, representing 7.1% of all cancer deaths. Incidence rates increase with age and vary across race and ethnic groups. The WPSI's recommendation for screening breast cancer in women of average risk states that women at average risk of breast cancer should initiate mammography screening no earlier than age 40 years and no later than age 50 years. Screening mammography should occur at least biannually and as frequently as annually. Women may require additional imaging to complete the screening process or to address findings on the initial screening mammography. If additional imaging, for example, magnetic resonance imaging, ultrasound or mammography, and pathology exams are indicated, these services are also recommended to complete the screening process for malignancies. Screening should continue through at least age 74 years, and age alone should not be the basis for discontinuing screening. Women at increased risk should also undergo periodic mammography screening. However, recommendations for additional services are beyond the scope of this recommendation. In terms of implementation considerations, decisions regarding when to initiate screening, how often to screen, and when to stop screening should be based on a periodic shared decision-making process involving the woman and her healthcare clinician. The shared decision-making process assists women in making informed decisions and includes, but is not limited to, a discussion about the benefits and harms of screening, an assessment of the women's values and preferences, considerations of risk factors such as life expectancy, comorbidities, and health status. Discussion and education related to screening should be culturally and linguistically congruent, particularly for patients experiencing health inequities. Women considered at high risk of breast cancer, such as those with a previous diagnosis of breast or ovarian cancer, or a known BRCA1 or BRCA2 mutation, previous high-dose radiation to the chest may require additional testing and closer follow-up, which are beyond the scope of this recommendation. Now, I would like to share how I have implemented this recommendation into my daily practice. While screening patients for breast cancer, the first thing I assess is the risks taking into consideration their family history, reproductive history, and any previous breast imaging, past medical and social history. Given that screening guidelines are for average risk women, it is critical to first determine if your patient is truly average risk. After discussing risk factors, I discuss the benefits and harms of mammography, emphasizing the ability of mammography to find breast cancer early and reduce breast cancer mortality. I highlight that about 10% of women will be called back for additional imaging, and about 1% of women will need a biopsy, and that if this happens to them, I will be available to answer any questions. Since it's critical to take into considerations our patients' values, I ask them how worried they are about breast cancer. Given that information, I advise them regarding my recommendation for when to begin mammography and how often to screen. In general, I recommend women begin at age 40, and if they're average risk and not particularly worried about breast cancer, then they may screen every other year. Finally, I remind them that there are different guidelines and that if they receive notification from radiology, that is different from what I discussed in terms of frequency of screening. I'm available to answer their questions and discuss those differences. There are many great resources from the WPSI, including full recommendations on breast cancer screening on our website, where you can also find downloadable resources such as the Well Woman chart outlining preventive services for women by age group and risk factors, patient education resources, and other How I Practice videos for other WPSI recommendations. Thank you for your time.